This computer. Hello and welcome to Thursday's Zoom. I hope you guys are all doing well with your sim chart. Jenny, how are you liking it?
I like it. I think I've almost completed all the exercises. I've done some over again, like the requisition ones and all. I find that a little difficult because you got to do it. You got to document it, then you got to do the requisition. So I struggle to figure out sometimes what's just documented and then what we order,
Well, I love the initiative of going in and and doing that. Also, if you look back at the textbook that we just finished with, the EHR, if you go into that book and look in the very back, there's some more scenarios back there that can be different, and maybe want to look up something to see if that's something you can practice with too.
Okay.
Well, today we're going to be looking at CMS 1500 forms, which is simply a claims form. It's a red and white form if it's paper. I'm going to show you this in case. I know that Jenny, we probably went through it a couple of times already, but I'm going through it again because there's going to be some things on NCCT about it. And I want everybody to know that this is not just an electronic form. It can be a paper form too. As a coder for 4 years, I probably used a paper form 10 times, and that was it. The rest went electronically. So there's going to be very few times that you're going to have to do these on paper, but in case you ever have to, I just want you to be familiar. So let me share my screen, and that's where we're going to start today. It's not the only thing we're going to do. We're going to look at an EOB. We're going to look at a denial, and then we're going to talk about those things. Share screen. I'm having to do things a little differently simply because I have to put you closer to me. All right, so can you guys see the 1500 form in front of you?
Yeah.
Yes.
All right, so we're going to take a close look at, and I know that it's fuzzy. I know it's not exactly clear, but when you blow things up on the computer, it's the best I can do. So line 1, you're simply going to be choosing what kind of insurance. If you're doing this on a typewriter, because y'all, at my coding facility, the typewriter we had was the old kind. It wasn't even the electric typewriter. It was the one before that, the manual, where you had to push the buttons really hard to type. Because these can't be handwritten. They always have to be typed. So hopefully your facility, if you have to ever do one hard copy, then you'll have a better typewriter. But simply line 1 is what kind of insurance do they have? Now, if you were doing this electronic, when you put your patient's demographic information in, you guys have been practicing SimChart, that it's going to automatically tell electronically what to put on this form, whether it's Medicare, Medicaid, TRICARE, or other. Block 1A is just the insurance ID number. Then it's the patient's name, address, and all of that good stuff. Now, if you come all the way over to 2, again, that is the patient's name. The name on this form, just like when you're putting the name in your documentation, in your EHR, in your sim charting, has to match what's on the patient's insurance card. Does that make sense? If it doesn't match perfectly to the insurance card, it's going to kick back, because when you're sending this claim form to the insurance, everything has to match. If you put in the wrong insurance ID number, it's going to kick it back. So everything that you have to put on here, you need to be accurate when you're putting in the demographics, so that when it transfers over to your claim form, it's going to be accurate information. Does that mean you're going to get it right every time? No, sometimes you're going to transpose a number, or the name's going to be a little bit different. It just depends. But always check when you get a denial or a claim comes back. Always check your insurance information first. Make sure the name is spelled correctly. Make sure the number is right. Make sure your date of birth is correct. All of those small things that you can get wrong. Okay, so if we look at 3, that's your patient's date of birth. Again, this will electronically populate from your demographics if you're doing this electronically. 6, it can be the patient relationship. This is a self patient. It could be a spouse, a child, or other. Patient status, single. Does this information look familiar from whenever you're putting it into the demographics, when you're putting a new patient in? This is all information that you're putting into that particular system. That's why it's important for it to be accurate, because it transfers over to this form electronically. All right, so if they had a secondary insurance, you would put it in, it would go into block 11. It's not block 11 when you're doing it in your SIMS, it's just on there. But if it were going to automatically populate, it would go into block 11. Okay, and you guys know that, or do you remember, Jenny, when we talked about the signature on file, where the patient actually has to assign a medical release form? This is where that would automatically populate here. That they're saying that we can send this electronic form to the insurance company, because without this signature, we can't release that information. So if they decide they don't want to sign this bill goes straight to them, right?
Yeah.
All right, so let's go down a little bit further. If you're having a referral, or if it's a referring physician and it's you're actually billing for that referring physician, this is where it will auto-populate here. So if we go down to 21, this is where our diagnosis codes go. So let's see, again, 16 is occupational therapy. 17, I've never used any of these blocks. I'm just going to hit the major ones. So here it's going to say outside lab. They didn't do outside labs for this patient, so it's a no. Again, this is automatically populated. Number 23, I want to call your attention, is prior authorization. What do you think that is? Jenny, I know that you know. Can you give us in your own words what a prior authorization is?
It's when the insurance company already authorizes something, I believe.
Right,
You gotta
Markira.
authorize it beforehand, I believe.
Beforehand. Markira, do you want to weigh in on that?
Yes, ma'am. The prior authorization, you basically get permission from the insurance to do the services so that they can pay for it.
Right, for a procedure usually, right?
Mm-hmm.
But we can also get prior authorizations for pharmacy too, for a prescription. How many times have we gone to the, I'm gonna say for myself, gone to get our sick child's prescription and they can't give it to us because they skipped the authorization process? So then the pharmacy will say, hey, we got to get prior authorization. So it's just saying that we're authorizing to pay for this. So prior authorizations are very, very important. All right, so in 24, this is our date of service, which just simply says this is the date that we did everything on. Then our place of service. I want to talk about this a little bit. So in our CPT manual, Markira, you haven't gotten into the CPT manual yet, but this is what it looks like. If we look on page, it doesn't even have a page. It's the very first page after your first cover, and it simply says place of service. So this is where this line B, 24B, comes into play. So 11 is simply place of service, office. So this is an office visit. Now, if it were a hospital visit, this place of service code would be different. These codes are pre-loaded. That loaded is not, trying to think of the right word. They're already put in and they're based on your CPT codes. So this is not something you have to figure out if it's sent electronically. If you're filling this out by hand, please remember where your place of service codes are. If you're in the office, it's easy, it's 11. If you code for an ambulance company, it's going to be different. If you're coding for an outpatient orthopedics, those codes are going to be different. The office is 11. Then D is going to be your CPT codes. The modifier is going to be next, then the charges. then the units, which normally is going to be just one unit for regular visits or regular things, because you can't charge a 94150 twice in one day. Okay, rendering provider ID number. I want to talk about this. This number is preloaded. When I had 12 doctors, I had 12 different numbers. This tells the insurance company which doctor is going to get paid. If you have 4 doctors in one group, do you think Dr. Davis is going to get paid for everybody's patients? Now, there may be a situation in the office where they profit share, but a lot of times that's not how it works. My doctors did not profit share. Whoever number is here was who was going to get that check from this patient. Does that make sense?
Yeah.
All right, and then down here is just going to be the doctor's signature, the doctor's address, and the tax ID number, patient's account number, and then the total. Those are just accounting things that would be normal. Okay, is there anything that you guys want to talk about on this CMS 1500 form?
Just the federal tax ID number that they give you that, right?
Yes, they'll give you that. I got it along with my when I called this an NPI number, a national provider identification is what it's called. But each one of the providers will have their own federal tax ID number. And when I made my own I had a little sheet with the numbers, the provider, the number, and the tax ID number. Now, sometimes tax ID numbers will handle the whole group. It just depends, but they will give you that. You may never have a reason to know that, Jenny. It may be so different for you. Remember, I've been out of the field for going on 5 years now. Things have probably updated and changed a lot, but I'm teaching y'all the way that I learned in case you ever have to go old school a little bit. So,
in this, like in the electronic health record, this is where we'll fill that out, or where you first, like, because I see there's like places to enter like payments and codes in there. Will you fill that out and this out for like a visit?
well, no. What will happen is, okay, let me walk through it step by step, so maybe it'll make sense. So say that you have a new patient come in. You put all of the information that we talked about up top into your EHR, which transfers to your billing department and your coding department. It's one system. So once the patient comes in, they see the doctor, say they have all of these things done. These things are not written here, they're written on the super bill. So the biller gets the super bill. She puts all of this in from the super bill, and it goes from the super bill to the insurance company. This is automatically filled out, and all of this is all the standard information is already electronically there. It's within the EHR system. Does that make sense?
Yeah.
I know that it's a lot of gaps in between there. Unfortunately, I can't show you a billing system, and I wish I could. I wish we could actually really do real billing. I've been pushing for a system that would allow us to do that, but so far we haven't found one. But billing is my favorite. I love it. I think it's fun. Okay, is there any other portion that we have a question about?
I don't
have anything.
Okay, so let's take a look. And I'm sorry, guys, our local neighborhood mascot Kitty, call him my desk Kitty, is wanting to get up and say hello. Let's talk about an EOB. Now, I've talked about EOBs a little bit, and but I just kind of wanted to pull up a sample again, and let's just talk about, we talked about deductible, co-insurance, all of that last week. So let's kind of talk about this again. So we're looking at the description, the service description in this area first, and it just says surgical charges, recovery room, medical supplies. It's going to give us a list. The date of service is all the same. It's an outpatient. So the patient went in and then went out on the same day. The billed amount, the reductions or the discounts, the covered amount. I'm going to move y'all over because I don't know if y'all are in the middle of my page. Then we have the health insurance responsibility. The covered amount is $2,200. We have the health plan responsibility. The deductible is $1,000. The co-insurance is $240. Total cost for just this first line item is $1,240. Do you guys have any questions about an EOB?
No, ma'am.
I just want to know, like when you filling out an EOB, well, we'd have to learn all the insurances and like what they cover, or like does each insurance have a set amount, or each person has a set amount?
Okay, you will not have to ever fill out an EOB. This is actually filled out from your insurance company after you send that claim form we just talked about.
Okay.
So it's going to show one or two things. It's going to show certain things have been paid, and then it may kick back and say, hey, we're not paying for laboratory services. And then it's going to tell you why. I'm going to show you an example of a denial. So far, I haven't been able to find an EOB and a denial. A denial can be an EOB, but I couldn't find anything on the same charges. So we're just looking at that examples. So this is an example of what a real denial form looks like. Now, I don't want to scare you, but as a coder, if you are coding and billing for a large facility, you're going to have stacks of these. It's just going to be how it works, because sometimes the insurance, it could be just something really, really small wrong. And I know it's hard to look at this with a bunch of black squiggle marks on it, but it has to, because this is protected health information. So this is an actual real one. This is not something that somebody made up to look pretty. This is an actual real document that somebody made safe to share. So this is a denial. What are they denying? They're denying everything. Why are they denying it? So let's take a look over here where it says GRP, RC amount. The GRP, I don't know why it doesn't say denial, but you're going to learn to look for example, CO 45. So you know that none of this got paid because CO 45. Every denial comes with a key or a glossary. See at the bottom of the page down here where it says glossary? CO means contractual obligation. The patient may not be billed for this amount. So it's CO and 45. Charge exceeds your contracted legislated fee arrangement. This charge to be effective 6107. Charge exceeds the fee schedule maximum allowable or contracted legislated fee arrangement. Okay, that's a lot of, I don't know what that means, right?
Yeah.
Okay, well, don't worry, because I looked up what this denial code means. So if you get a denial and you do not understand what it means, I'm going to just read you the common reasons. Item or service paid Medicare allowed amount, item or service paid the patient's deductible and or co-insurance, item or service paid with partial unit. Explanation and solutions. It means that the bill, which is more than Medicare allowed amount, is adjustment. You just write it off. So if we go back here, this patient cannot be billed for this. It must be adjusted and written off. This is a Medicare denial form. All right, so we know patient A, we're not getting paid any of that money because what did Medicare tell us we had to do? Right here, we have to write it off. All right, so let's go to patient B. So we see all of this. It says it's denying 225.70, CO 45, which we just read, PI 97. So let's look at PI 97. Prior initiated reductions in the options of the payer. The adjustment is not the responsibility of the patient. Do we need to go any further than that?
No, ma'am.
Because it just said that patient is not responsible for this. And plus we have CO 45, which says just adjust it off. So the doctor is not getting paid either one of these claims, either one. And we don't have all the information. If we did, we could go back and look, maybe they've met their deductible, maybe whatever the reason is, he's not getting paid. And when Medicare says they're not going to pay something, they're not going to pay it. And then the same thing with patient C, CO 45. We just need to adjust it off. Now, was that confusing at all?
No.
No.
Okay, this is just a snippet of Medicare, just a snippet. Medicare and Medicaid are the easiest for me because to me, they're cut and dried. Some of Medicaid is cut and dried, not all of it is. United Healthcare gives me really bad headaches. Hopefully it's updated since 5 years ago, but
Still a headache.
there's still a headache.
Mhm.
And none of them speak English, and I'm just saying. Sorry, another instructor is calling me. They should know that I'm on my 2 o'clock Zoom right now. So, okay, so I just wanted to kind of give you a little view, a little information, a little bit more clarity on some of the things that you could be in charge of at the office. Now, the last thing that I want to show you is an insurance card. When we talk about copays and we talked about deductibles and all of these different things, sometimes you're like, how do we know what their copay is? How do we know what they need to pay when they go into the doctor's office? Well, 99% of the time, it is already on the insurance card. So if the information does not need to be updated, which is one of the first things they always ask you when you go to the window and check in, right?
Mhm.
Mrs. Westerman, is there any changes to your insurance? Do we need to update anything? Then that receptionist and the person who checks you out, they can pull your card and see what your copay is and all of that for doctors, for your primary care physician, for a specialist, for the emergency room. So when we talk about copays, I know it sounds, when we just talk about it in a small frame, it may seem complicated, but it's usually listed on the insurance card. Make sense?
Yeah.
Does anybody have any questions?
I don't have any.
No.
So was this helpful? Did it give, I just a little feedback. Did it give you information that you find valuable?
Yeah.
Yes.
I feel like sometimes with our program, kind of there's gaps in the middle where I'm just teaching you the information, but you never know anything about it in the real aspect. I wanted to show you guys some real aspects, and I'm going to work hard to continue to do that. So I told you guys it was not going to be complicated today. We're in a module where I don't have to lecture whole chapters, right? So we're enjoying not having long lectures or long Zoom calls. Please know that if you need me, I am here. Just let me know. Have a wonderful Thursday and a great weekend.
Thank
Thank
you. Bye, everybody.
Bye.